Good afternoon. My name is Aleksander Skotnicki. I was asked to carry with my partners second session. We have a great pleasure to have first speaker, who is Dr. RAMON GARCIA-SANZ, famous Salamanki. There is sister cities interaction between Kraków and Salamanca. Probably you know it already, so it's the reason why you came to big cooperation with us. Dr. Sanz is head of molecular laboratory in Salamanca University. I am glad that he is young research fellow, only 30 years old, and he is going to speak about MRD in multiple myeloma. And in my long-lasting hematological experience, I remember that we obtained, even with Leukeran steroids a priori 40 years ago, kind of clinical remission, disappearance of the symptoms of our patient, mainly bone pain, disappearance of kidney abnormalities, normalization of protein parameters, and of course, disappearance of plasmacytes from inaspiration of bone marrow. The problem was that even when we get molecular remission, the problem is whether it's a good point to start a continuation of a therapy. For many years, we considered multiple myeloma, even after treatment, as some kind of smoldering myeloma that eventually all multiple myeloma patients relapse one day. So it was necessary to control on many levels. Now, when we have molecular measures of remaining myeloma, probably the situation is much better. Professor Sanz, I'm very glad to invite you to speak to us, a little bit older hematologists, what you could find out and suggest us based on modern advances in molecular biology of multiple myeloma. Yes, please.
Thank you very much. Good afternoon, and thank you to all of you for your interest, and especially thanks to Dr. Jurczyszyzyn for having invited me to give this talk about minimal residual disease in myeloma. One of the things I have to say is that when he invited me 1 year ago to be here today, I was working in the University Hospital of Salamanca, but now I moved, in the meantime I moved to Madrid, and now I am in another hospital, which is the General Hospital Gregorio Marañón in Madrid. Okay, MRD in myeloma. Around 10 years ago, the International Myeloma Working Group provided consensus criteria for the definition of multiple myeloma that have been stable for a long time. By contrast, 2 years later, they provided also a consensus criteria for evaluating the response after initiation therapy. And it was provided the terms of progressive disease, minimal response, very good partial response, stringent complete response. However, at that moment, the technology was not advanced enough to provide this stable criteria, and these criteria have been challenged up to now. And with this, we have some other definitions that have been moved for some, in some cases. One is the obtention of stringent complete response with negative MRD, negative minimal residual disease, by imaging, or by sequencing, or by flow cytometry. And also, in a step forward, we can say that we can add the term of sustained MRD when a patient has at least 2 samples without MRD that are separated by at least 1 year. And after that, we can say more and more, after 3, 5 years, etc. Because the longer the MRD sustainability, the better the survival. the methodology has dramatically evolved, and so myeloma at this moment we can say is at the forefront of the MRD assessment, but also we can say the opposite, that the MRD assessment is at the forefront of myeloma management. It's a double direction way. At this moment we have at least 4 different technologies to evaluate the minimal residual disease in myeloma. One is the mass spectrometry that targets the monoclonal component in the serum. And we have also 2 different technologies, next generation flow and next generation sequencing, to detect tumor plasma cells, aberrant cells or clonotypic cells in the peripheral blood and especially in the bone marrow. And also we have to remind that the PET-CT can be also a tool for MRD assessment because it is capable to detect aggregates of active cells intramedullary or extramedullary. Mass spectrometry is the youngest technology to arrive to this field, and this is very relevant because it is more sensitive than immunofixation. This is an example of a patient with 5 samples, in which the 4th sample is negative for immunofixation, providing the complete response assessment. With the free light chain in the right panel, we can see that 2 samples are positive, but 3 are negative, despite the poor outcome of this patient, while the mass spectrometry for IgG kappa is positive in all 5 samples, corresponding to this poor outcome that this patient had, relapsing before 2 years. When we applied this methodology to a series of patients, we can obtain good results, seeing that in the green curve, patients who achieve a negativity for mass spectrometry do much better in terms of progression-free survival than the patients who are still positive. As this can be seen in this study from the Spanish myeloma group. And also some other groups have reproduced the results. For instance, this study that has recently been published by the Chicago University in collaboration with many Polish groups, in which we can say that patients in the blue curve do much better because they achieve a mass spectrometry negativity. But MRD is probably the most extensive and positive results have been obtained in bone marrow assessment. We have 2 techniques. One is flow cytometry that was initially evaluated in the early 90s, when we were able to see that patients with a specific aberrant phenotype, in this case CD38 positive, CD19 negative, CD56 positive, CD45 negative, the cells in yellow, can be distinguished very well at diagnosis from the rest of the cells in the global bone marrow, or during the treatment in the gate of CD38 positive cells, providing that there are normal plasma cells that are completely different to the myelomatous plasma cells. This patient, after the therapy, still has minimal residual disease positivity, with a sensitivity of 10 to the minus 4, and most probably 10 to the minus 5 at that moment. So that means that we can detect 1 single plasma cells, tumor plasma cells, among 100,000 global cells in the bone marrow. And the application of this methodology to series of patients provide also good results. Patients in the green curve with an MRD negativity do much better than the rest of the patients, including those who are in complete response, but who are MRD positive, who are immunofixation negative, but MRD positive, that are the patients with the dark blue line, in both PFS and overall survival. The second methodology that we have to evaluate the cells in the bone marrow is next-generation sequencing, but it is not this sequencing that is represented in this panel. It's the next-generation sequencing in which we use a big panel to detect many different alterations in the bone marrow of the patients with myeloma at diagnosis. We can detect translocations, mutations, the rearrangement, copy number variations. But this methodology has the the sensitivity of 10 to the minus 4 as much, because we can read only 10,000 reads, maybe 30,000 reads. We can detect one abnormal allele among 30,000 normal alleles. But if we take into account that every cell has 2 alleles, we can detect only one abnormal cell among 15,000 cells in the best conditions. So we have to go for another approach, which is the read of the specific sequence of the immunoglobulin rearrangement in the gene of the heavy chain of the immunoglobulin. Sometimes it can be done also in the light chain, but it's more used the heavy chain. With this methodology and a simple fragment analysis, we can detect very well patients with a monoclonal component at diagnosis or during the therapy without achieving complete response in the middle or in the bottom. We can see the figure of a polyclonal sample in which the patient has no tumor cells, but in this case with a sensitivity of 10 to the minus 3, 10 to the minus 4. We have to go for a step forward using adapters in the primers that amplify the fragment, the rearrangement, the specific rearrangement, and read the sequence of all of them. Let's say 500,000 alleles, 5 million reads is possible. Then we identify perfectly situations of clonal, of the clonal imaging, in which we can see here in this part, the green column with that represents 4.7% of the alleles are clonal, are exactly the same with the same rearrangement. The rest are polyclonal. In this case, the methodology can detect the specific sequence, in this case a VH118JH4, and in the middle the sequence will be exactly the same for all plasma cells. And this is what is specific of our cells. If we see this rearrangement in 2 different cells, we will say that these 2 cells are clonally related. They belong to the same clone. Then I treat my patients, I repeat the methodology, I read 1 million fragments and interrogate the software about our specific rearrangement that we detected at diagnosis in the patient, and the software will say, okay, you have 1, 2, 3, 5, 6 rearrangements equal to the specific rearrangement of the plasma cells, so we have 6 cells in 1 million cells approximately. So this patient is a positive MRE with a sensitivity of 10 to the minus 6. And when we apply to the patients again, we have very good results, distinguishing very well between patients who are negative in red from those who are positive in black. And in the right curves, we can see a 75% duration of complete response for 10 years, which is quite similar to the disorders that we call curable. So we are close to the cure of part of myeloma patients. So we have these 2 methodologies. Which one is better? It's very difficult to answer this question, to say if you can see this approach in the middle. We can see that with a next generation sequencing detect more patients negative for flow, positive for next generation sequencing than the opposite, negative for next generation sequencing, positive for flow. So it looks that next generation sequencing is a little bit more sensitive. This is something that we have always said, although we have to recognize that these methodologies were done with the old-fashioned flow cytometry, not with the new one, next generation sequencing, that promises a 10 to the minus 6 sensitivity. So when we use these 2 methodologies in similar conditions, we have really 2 interchangeable next generation MRE methods. And also it does not depend on the technique that we use in next generation sequencing. The other one was done with the service of adaptive. This is done with another kit in our hospital. So the techniques are really similar. And what about mass spectrometry? If we use this paper from the Chicago University and the Polish groups, we can see that with mass spectrometry, next-generation sequencing, next-generation flow results are also comparable, maybe are better with, a little better, bit better with the next-generation flow, but we can say that there are no real differences between the three approaches. So if we have to decide which methodology can we use for next-generation sequencing, we can say that we will have similar results and we will support our decision based on the advantages and disadvantages that we have for all three methods. The applicability is very high for all, maybe 100 for mass spectrometry, 90–95% for the other two. There is no need for baseline sample for flow cytometry. The sample requirements are 1 million cells for next-generation sequencing, 5 million for flow cytometry, it's very easy in the bone marrow, or 1 tube of serum for mass spectrometry. The sample processing can be delayed for NGS and mass spectrometry, not for flow cytometry, but in contrast, flow cytometry can provide you data in 3–4 hours, less than 1 day. The time consuming is high for next-generation sequencing and maybe a little bit high for mass spectrometry because it's very quick, but you have to accumulate samples. So this is because it's not so convenient as flow cytometry, which is very low time consuming. The sensitivity is 10⁻⁶ in both cases, not applicable for mass spectrometry. The specific rearrangements that were necessary for the old ASO-PCR approach that is used usually in lymphoblastic leukemias or mantle cell lymphomas is not the case here. We don't need specific rearrangements. The cost is higher for next-generation sequencing. Clonal evolution is detectable with NGS, but I have never seen any clonal evolution in the immunoglobulin gene receptors. And the expertise has to be very high for NGS and flow cytometry, not so high for mass spectrometry. That can be done with a technician. And the availability by the technology is available, very available, at least in my country, in flow cytometry, not for next-generation sequencing or mass spectrometry. And for the patient, obviously it's more available than mass spectrometry, which requires only a single tube of serum. The other two requires bone marrow. And we have also to remember that these techniques can be complementary. So we prefer at this moment, if somebody asks me what prefer, I would say the three, and also some others. For instance, don't forget the use of the complementary approach of PET-CT, in this case of patients that were treated for CAR-T, patients who achieve an MRD negativity without extramedullary disease did much better than patients with MRD positivity or who had extramedullary disease at the treatment with the CAR-T cells. At the end of the day, what we can say is that we have a very good MRD methodology for evaluating our patients. We can distinguish very well the two situations, positive versus negative. And also we have the promise of a very good correlation between MRD negative rates and PFS. And this has convinced the advisors of the FDA, to endorse minimal residual disease for accelerated approval of endpoint, as an accelerated approval endpoint for accelerated approvals of drugs in multiple myeloma, which is something that has been approved by the advisors and probably will be done by the FDA in the next weeks or months. So therefore, from now on onwards, it will be very important to adhere to the International Myeloma Working Group guidelines to generate high-quality data with the possibility of cross-trial comparisons. We have to report MRD negative rates in the intent to treat population and to consider pre-specific time points in addition to the complete response to minimize MRD data, missing MRD data. We have to prioritize the first bone marrow pool for MRD assessment in order to avoid hemodilution and false negative results. That is a problem for these methodologies. We have to provide the calculation of the limit of detection in each sample, because the limit of detection is not fixed for all cases. It's highly dependent on the quality of the sample. So it has been calculated in at least 95% of the patients will have to provide the results with the limit of detection. And finally, it's important to recognize that MRE kinetics is very informative. It's also very, very important. This is an example about the kinetics. This provided by these 5 trials, in which we can see in the top the patients who are negative for 2 different samples do much better than patients who are continuously positive, or who became from negative to positive, that are the yellow and the red curves. So it's important to see that our result of MRE negativity is consistent. And if we are able to perform almost 1,800 MRE assessments, as we did in 2 consecutive trials in the Spanish group, we could leverage MRE kinetics to identify 3 unique patient subgroups. One is the sustained MRE negativity, the blue one, do much over 90% PFS and overall survival at 4 years. Those with detectable but stable MRD levels with a mild treatment in the PFS but not in overall survival, the green curve. And finally, in the red, patients who have a detectable and evolving MRD levels, in which the levels of the second and the third assessment are higher than the previous one, and who have a very poor PFS and also a poorer overall survival. Okay, however, so I have demonstrated that MRD is very important, but it's not very used, because it is difficult to provide an answer directly to our patient. This is something that we are trying to find, as this is, to answer this question. Can treatment be interrupted in some MRD negative patients? The Spanish trial that evaluated this has provided some clues. So patients who were in response were divided in 2 groups, one with lenalidomide and dexamethasone, or lenalidomide and dexamethasone and ixazomib for 2 years. And after that, when the patients were finished this maintenance, were evaluated for MRD. Those who were MRD negative stopped the therapy, and those who were MRD positive continued the therapy for 3 years. And the results are these. Independently of the stop or not, patients who were negative for the MRD, despite they stopped the therapy, did much better than the patients who were MRD positive, despite they continued the therapy. So with this result, I think that we can say reasonably that we can stop the therapy if our patient is in complete response for 2 years with MRD negativity. Maybe because at 4 years we have more than 82% of the patients free of relapse. So the question here could be, so for the 18% patients that relapse, despite they were MRD negative, can we anticipate who of them are going to relapse? And the answer has been done by 2 different papers, one from the Spanish group and the other one from the Italian group, in which they detected that there were 4 risk factors to anticipate the MRD repositivization. That is the presence of high-risk cytogenetics, an international score system of 3, or more than 0.01% circulating tumor cells at diagnosis, and the presence of a late achievement of MRD negativity beyond 1 year. And in this case, so if patients have at least 2 of these parameters, this is a red flag that could say that in these patients, maybe the interruption of the therapy could not be a good idea, despite they are in MRD negativity. Therefore, if we believe that with this, with all this information, we could have an hypothetical scenario to assess MRD in our patients. That could be to use MRD assessment in bone marrow very intensively every 3 or 4 months during the first part of the therapy, during the intensification, during the induction or the intensification, and after that reduce the number of bone marrow assessments, but substitute them with blood assessments, with mass spectrometry, with the next-generation flow or with next-generation sequencing in the blood, that are also the methodologies that are being under study, but also without forgetting the imaging in all these patients. So, in summary, what I have tried to emphasize here is that there is no precision medicine without precision diagnostics and disease monitoring, and in the marrow and also in the blood, that are key tools for multiple myeloma management. And with that, I want to thanks to all my old group, my new group, the group from Bruno Paiva, who has provided some of the slides here, and of course from the Spanish myeloma group, and of course to all of you for your interest. Thank you very much for your attention.
Thank you very much, Professor Sanz. We could find out that during the last 30 years you make and your team wonderful progress in evaluating the level of remaining multi-myeloma in our patient. I think it's very important, but still I'm coming to my question a priori, whether people still could relapse after many years being MRD negative. And the question is, how, to what extent you could evaluate the group of the patient being MRD negative and who will not relapse, let's say, after 10 years. Do you have such data?
No. So long follow-up is not available at this moment. The only thing that I can say is that we all have some patients who have been free of disease for more than 10 years. And when we have evaluated some of these patients, all of them are MRD negative. It's the only thing that we can say. But I agree that it's possible that all these patients can relapse in the future. It's difficult after 10 years of sustained complete response, especially if there is an MRD negativity, but we don't have enough data to say absolutely sure that this patient is not going to relapse.
And do you think that at special threshold of MRD, immune system could overcome and keep this low MRD in check and patient will not relapse?
Okay, for me, the best threshold is no MRD detection. I think that this should be our endpoint, if possible. But we have to remind or to keep in mind that there are a small group of patients who don't achieve complete response with MRD negativity, that remain stable for many times, that usually have the so-called MGAS profile. So these patients can be just followed for a long time without any therapeutic intervention. It's something like a smoldering myeloma status after therapy.
Do you think it is because of immune system keeping in check with MGAS situation?
Oh, it's a possibility, but we don't know, because it's exactly the same what happens in MGAS. We don't know which patients are going to progress to myeloma or not, although we have several clues that are usually related with the load, with the tumor load, the size of the monoclonal component, the size of the abnormal plasma cells that are in the plasma cell compartment, the type of the monoclonal component. This is something that are clues to say what patients are going to progress or not, but at the end of the day, we don't know exactly. And the immune system, we tried to evaluate also the immune system in the past about this aspect, but we couldn't get a formal answer to this question.
But I'm sure that there must be some interplay, if I can say so, between gas and immune system, and some patients, they could last for quite long. The lecture is open for discussion, please.
Great talk. My question is more about how the FDA approved MRD as an endpoint. The FDA approved MRD as an endpoint, as you showed. What do you think is going to be EMA's position? Will EMA, are they also expected to comment on MRD negativity as an endpoint for clinical trial approval? For EMA?
For EMA?
EMA, sorry. Yeah, EMA.
I don't know. I don't know. I think that we will fight about this because we believe in MRD detection. But I don't know what's going to do they. Probably, I presume that they will follow FDA.
Yeah, but from what I know, unfortunately, they were not convinced by the same data that FDA took. So they asked for a new analysis, so it will not come soon, unfortunately, for me, him, and us all here. So they will follow, but not soon after. That's what the people in charge of this ODAC told me.
If there is no any other question, thanks very much again. Best regards to Salamanca. And I am passing microphone to my co-chairman, Professor Machaliński.
Grzegorz Charliński first.
The next lecture is how I treat high-risk multiple myeloma, and I invited ELENA ZAMAGNI from University of Bologna.
Okay, thank you. Good afternoon, and a true thank you for this very kind hospitality. It was very kind from Artur to present us this tour this morning. I enjoyed a lot, so really thank you. It's my first time in Poland, first time in Kraków, so it's a wonderful town. So how I treat high-risk multiple myeloma. We all know that patients with multiple myeloma have different prognosis. And with the addition in the last 10 years of all these new treatments, immunotherapies, bispecific CAR-T, we know that some patients are really experiencing a very, very prolonged progression-free and overall survival. And we are starting to speak about curing multiple myeloma. At the same time, we know that there is a small, fortunately, fraction of people which are still experiencing a very bad prognosis, and those we are calling high risk, less than 5 years of survival, or ultra high risk, less than 3 years of survival. So for this reason, it's very important to risk stratify patients. However, the current efforts are not enough. So we all rely on the ISS, revised ISS, and maybe revised 2 versions of ISS. They are something, so a lot of job has been done, but we are not happy only with this score, which are taking into account albumin, LDH, beta-2-MYC, and cytogenetics. So I put in this slide many other factors that, to my opinion, are significantly influencing the prognosis of patients. And what we are aiming for is for a better risk stratification, which is including, for sure, at least extramedullary disease, plasma cell leukemia, circulating tumor cell, as well as characteristic of the patient, so frailty and performance status. So the first point is cytogenetic. That is maybe the easiest, but it's not true, because we are not happy with the current risk stratification in cytogenetics. We have relied on this for many years, but we know now several things. First of all, we know that regarding deletion 17p, also TP53 mutation matters. So this is pushing us to look for FISH, but also to look for the gene expression profiling of p53. And those patients with both mutated are at highest prognosis. Then we know a lot more about 1q abnormalities. So there is this gray zone between amplification and gain, and probably it doesn't matter so much because often it is associated with other abnormalities. Also regarding 1p, we know now that what matters truly is the biallelic mutation of 1p, but this can be seen only by NGS and not by FISH. So for sure, there is a new classification of cytogenetic high risk that has been done for 1.5 years now. And lastly, the paper is currently submitted to the GCO, so I hope that soon we will have a uniform definition of high risk, because this is not the case until now. If you look in so many clinical trials, the definition is completely different. But we also learned another thing, that the number of genetic lesion matters. So one thing is to have one abnormalities, one thing is to have 2 or more, apart from deletion 17p, which is weighting a lot, enough to be alone. So for sure, ultra-high risk patients are those carrying 2 or more cytogenetic abnormalities. And we know this from more modern treatment. So we know even that in the era of quadruplet, very potent quadruplet, so anti-CD38 monoclonal antibody plus either VRD or KRD, those patients experiencing the worst survival, as you can see here, are those with 2 or more cytogenetic abnormalities. So the prognosis improves significantly for the general population or for those with 1 cytogenetic abnormalities, but not enough for those ultra-high risk. There has been, in the last years, have been many papers showing the independent prognostic relevance of circulating plasma cells. This also led to the new definition of plasma cell leukemia that currently is 5% of plasma cells, circulating plasma cells, so not as it was before, 20%. But we also know that very small fraction, 0.2, 0.7, the precise cutoff is not yet there, matters. So we know that those patients are at higher risk of losing the response, at higher risk of progression, and at the end of lower overall survival. Also, we know very well that one of the worst things that you can have is extramedullary disease, and now it has been clearly defined as something which is outside the contact with the bone marrow microenvironment, so in soft tissues. And we know that the prognosis of those patients, whatever they are receiving, is very bad. Fortunately, up front, the incidence is low, below 5%, but if we are going in patient treated with 3-4 prior lines of therapy, the percentage is raising up to 40%. So this is a true issue in the setting of immune therapies, CAR-T, bispecific, and so on. So all those are so-called static risk factors. But another very important prognostic factor is emerging, the so-called functional high risk. Why? Because with our modern treatment, most of the patients are staying in remission, at least enough to get to the subsequent treatment, to have access to the new treatment, to clinical trials. But if you are relapsing 12 or 18 months from your diagnosis, so either 18 months from diagnosis or 12 months from the autologous transplant, your prognosis is bad also because you have to run after the treatment, and the patients are relapsing on the best treatment we have, so quadruplets or other stuff. So their prognosis is really bad. And the upset, to my opinion, news is that some of those patients are standard risk. So the definition of standard risk is failing for sure. They are not that much, around 12%, but it means that they were misclassified as standard risk because they are at very high risk. So going to the treatment, current guidelines are not risk stratifying. So these are for Europe, but this is a similar picture also in US. So you can see that the recommendation for first-line treatment of younger patient is the same, whatever the risk. So DARA-VTD, VRD, they will be reviewed soon with the introduction of the newer treatment. These regimens are working very well. The Cassiopeia trial, DARA-VTD, was recently updated, and look at the median PFS, 83 months. So very prolonged PFS for the general population. Look at the Perseus trial, DARA-VRD, just published. Of course, the median PFS has not been reached yet, but is projected to be close to 9 years. 9 years of PFS for the general population. But what about high-risk patients? What, to my opinion, is a very good news coming from the Perseus trial is the rate of MRD negativity 10 to the minus 6 in high-risk patients. In very high-risk patients, it's difficult to get MRD and mostly to get a sustained MRD. So this is the first point. You have to get a high rate of sustained high sensitivity MRD negativity. And maybe with these new quadruplets you can. And this is coming also from the ISCIA trial. So isatuximab KRD, look at the percentage of people reaching 10 to the minus 6 with the quadruplet versus the triplet. So whether in standard risk patient, whatever you're receiving ISA-KRD or KRD, your percentage is similar. When you're going to very high risk patient, the advantage, the delta between the quadruplet and the triplet is very significant. So what does this mean? You have to push all your high-risk patients into sustained MRD negativity. This is the first concept. Why? Because this is the only way we can have to modulate the prognosis. I'm not claiming that we overcame the bad prognosis, but at least we can improve the prognosis. Look at the curves. Those patients in sustained 1-year MRD negativity are having a similar PFS than standard risk patients. So what about double autologous cell transplantation? For many years, at least in Italy, and I know in many other European countries, this was the way to go for high-risk patients. Are we convinced enough? My answer is no, because we have contrasting results coming from 2 different prospective randomized trials with a different definition of high risk, with a different treatment, a different follow-up. Nevertheless, both this EMN02 and Stamina trial showed that at least there is an improvement in PFS if you are applying double transplant. However, what are the pitfalls of the current use of double transplant? The definition of high risk was totally different and not appropriate and not modern in that 2 trials. We don't know anything about what double transplant is doing in the quadruplet era and in the immunotherapies era, because none of this trial were including anti-CD38 monoclonal antibody. And also, in that trial, the rate of 10 to the minus 6 MRD negativity was very low. So we cannot drive a definite conclusion. Fortunately, the French colleague ran this very, very good trial that has been closed for enrollment. The first data will be presented at ASH this year. And you can see this one is the first attempt to modulate the treatment upon MRD. And what they did here in the MIDAS trial is to consider only functional risk. They deleted completely the genetic risk. So the patients are receiving a common induction ISA-KRD per 6, and then according to MRD, they are following different routes. So they decided to consider more functional risk than static risk. And you can see that the patients consider standard risk because our MRD negative will be have been randomized to receive or not 1 single auto-transplant, MRD positive patient double transplant or single transplant. So maybe we will have some answers from this trial, despite probably not all of them, because as I said, the stratification of patient is not based on static risk, genetic risk, so I'm not sure whether this MRD splitting will be totally comprehensive of all the patients. Another big issue, to my opinion, nowadays with high-risk patients is maintenance. We are happy, I don't know, maybe a little bit with current maintenance, LEN maintenance. We are not happy of the duration of maintenance. Currently is until progression, and all of us would like to end the treatment somewhere, somehow. But we are for sure not happy in high-risk patients. LEN alone is not able to keep the patient under control for a prolonged period of time. So what can we do? Some attempts have been done adding proteasome inhibitors, but we lack a randomized trial because some trials were comparing, for example, bortezomib with thalidomide, which is not up to date anymore, or we have this Emory experience with VRD, which was quite good, but it was not randomized. So we don't have that much information, but more recently with the Forte trial, the Ischia trial, it has been shown that a doublet maintenance, so PI plus LEN, may matter. You can see here that patient with double EAT receiving KR for 2 years after induction, transplant, and consolidation are experiencing quite a good results. However, they are not identical to standard risk patients. So for sure, that's exactly not the same. So all that I showed you are retrospective analysis of trials that were not dedicated to high risk. So what, to my opinion, has been an improvement in the last year is the attempt to treat specifically high-risk patients. So I will present you 3 trials, but they are phase 2, not phase 3. And what is important, to my opinion, they are not that big, but they showed that it's feasible. It's feasible to dedicate a trial specifically to high-risk patients. What are the problems? The definition of high risk is totally different in these 3 different trials, and the trials are not randomized, so probably they will not lead to authorization of the drugs and to registration of the drug. However, you can see here, this is the first trial, the GMGG concept trial, using ISA-KRD. They all show a very high rate of MRD negativity, 10 to the minus 5, 10 to the minus 6, and also sustained at 6 months, 72%, at 1 year, 62%. So if we believe in MRD negativity in high-risk patients, for sure these are good results. Similarly, this is a French trial with DARA-KRD. You can see, however, here as well, very high rate of sustained MRD negativity. And the third one is coming from the UK group. In this case, the treatment is DARA-CVRD, so a little bit weaker as compared to the other, but similarly, the median PFS is not that bad. So for sure, a possibility for those patients is to use intensive quadruplet for induction, transplant, consolidation that are pushing 2/3 of the patient or more into sustained MRD negativity. What about the treatment of extramedullary disease? A very big effort was made by our friend and colleague Meral Beksak during the pandemic era. She was able to enroll 40 patients in this phase 2 prospective trial. It was a very big effort. And she performed analysis, genomic analysis of the bone marrow matching with the extramedullary lesion, treating patients with DARA-VCD plus or minus autotransplant. So once again, the feasibility maybe was so-and-so because it was very difficult to enroll those patients in the trial, but the results were quite good in terms of response. But what, to my opinion, was good is the demonstration that in those patients you have to go for both MRD negativity in the bone marrow and metabolic response by PET-CT or MRI. So the importance to check also outside the bone marrow in these patients that are for sure still an unmet need, and we know from our US colleague in real life that those patients receiving CAR-T in real life with extramedullary disease are doing bad. They are responding, but they are experiencing a significantly shorter PFS and OS. So maybe in those patients, in particular, if they are receiving IBSAL, which is a little weaker as compared to cilta-cel, something else may be done, and there are this real-life experience with pomalidomide to enhance the T-cell response after CAR-T. So we may think about this strategy to improve the response in those patients. Or another way to go is to target 2 antigens contemporary, and this redirect trial showed that in extramedullary disease, this may be the way to go to overcome antigen escape, so at the same time to target BCMA and GPRC5D, because those patients are escaping. So those patients have 2 problems. The T lymphocytes are not getting into the extramedullary lesion, and Leo Rasche just published on Blood a few weeks ago this, but also that there is a lot of antigen escape. What about functional high risk? I show you that the patient relapsing very early on are difficult to treat. I think that very good news are coming here from the CAR-T setting, and I'm showing here the CAR-T2 cohort B analysis plus a sub-analysis of the CAR-T2-4, the trial that it was shown before, showing that in those patients with early relapse receiving cilta-cel in second line, they are obtaining a very high rate of response, and the duration of response is significantly longer as respect to the first line. So we have a hope here for those patients that we don't know how to treat them. Maybe with CAR-T we are able to change their history and to get into a different story. My last slides are on the elderly population. So once again, for the elderly population, one unique treatment which is not stratified. The complication here is that in elderly patients, we have two enemies. One is molecular genetic risk, the other one is frailty. And unfortunately, sometimes we have both present. So whether one of the two is present maybe is a little bit more easy, but if a patient is frail, plus with cytogenetic high risk, that's a true issue because the two things are going, of course, in opposite direction. So also in the setting of newly diagnosed non-transplant eligible patients, we had a lot of improvement in the last years. So we know that DARA-RD, it's a wonderful treatment with a very prolonged PFS, close to 60 months. We also had very recently the results of ISA-VRD, which once again showed in the elderly population without transplant a very high rate of MRD negativity. So for fit patient, for sure, probably this new quadruplet is the way to go because similarly to young patient, in high risk elderly patient, not frail, you can go for a very high rate of MRD negativity because we know that with DARA-RD, patients with ultra-high risk are not doing that well as the general population. But what we do with frail population? With frail people, we have to adapt the dose. So it is true that we can apply the standard regimen. DARA-RD and DARA-VMP are feasible also in frail patients, but we had published two very important studies, to my opinion. One is coming from Italy some years ago, showing that people with frailty can go for len-dex and then len without dex. So dex sparing regimen, and probably in routine practice we are all doing this, but this study formally demonstrated that the results are identical. You can see there the progression-free survival curve. So this is a way to go. And also the French group presented the initial results of their trial comparing DARA-len versus RD, once again showing that sparing dex in elderly frail population matters. You can obtain the same results in terms of response and also some MRD negativity. So I'm going to the conclusion, and my conclusions are, first, we have to correctly risk stratify the patient. It's not, everything is not done. We have to improve and we have to go further, to keep together all that it has been demonstrated in the literature and try to build a better risk stratification. The new treatment for sure may improve the prognosis, so I'm sure that the inclusion upfront of CAR-T cells and bispecific may improve also the prognosis of this very high-risk patient. We should try to include this patient in specific trials, or at least to make sub-analysis dedicated to this very high-risk patient. For the time being, what can we do? What I do, we are still going on performing tandem transplant in very high-risk patients with the new definition. I have to confess that despite not available in the literature, we are already using the new definition of high risk. We have to try to push the most possible our patient into 10 to the -6 MRD negativity. My suggestion is not to leave treatment too early in very high-risk patients because their results is not identical of the general population, and we have to improve maintenance. We are not okay with just len maintenance in those patients. And with this, I thank you for your attention.
Thank you very much. Any question, comments?
Yes, please.
Thank you. Great talk. So I know ideally we should use now a quadruplet if somebody is, older and we can use it. But if there's a frail patient who's high risk, and you can only choose either between DRD and VRD, which one will you choose?
Oh, that's a 1 million question. Yeah, in frail patient, you cannot go for quadruplet, definitely. DARA versus V, that's old story, never solved. We don't have face-to-face, DARA-LEN versus PI-LEN. We know from the French study companion to the IMRO study that the PI matters because they tested DARA-RD versus DARA-VRD. So we know that quadruplet is better than triplet even with DARA. Yeah. So it's difficult to say. For sure, DARA is better tolerated. So what we are doing in Bologna, if the patient is frail, we are going for DARA-RD. But if I have to tell you that I'm happy about it, maybe no.
Thank you.
It's a great talk, and my question is regarding primary plasma cell leukemia and secondary plasma cell leukemia. We changed the definition, of course, it's 5%, but I believe 2 will be better. Yeah. How you treat such high-risk patient in your institution? I mean, primary plasma cell leukemia and secondary.
Okay, with primary, it's a little bit easier. What we are doing is a joint venture of 2 recommended regimens. So we are doing DARA-VTD PACE, which is not formally approved, but you can merge the 2. So this, what we are thinking that in the first cycles to add the chemo, it matters. It can reach maybe places where the cells are going and cytoreduct very quickly. So this is what we are doing. Then we are going on with DARA-VTD or DARA-VRD, hopefully soon, the double transplant and so on. Secondary, it's really tough because in that setting, PACE or whatever chemo is lasting very few, is not giving you the time to do something else. Sometimes I did PACE as a bridge to bispecific. We cannot get into CAR-T because it's too explosive. So it's more difficult for sure. Chemo, it's really lasting very, very too short time, not enough.
Maybe I ask you on your personal opinion as for the double auto stem cell transplant in high-risk patients. Would you prefer tandem autologous stem cell transplant versus further lines of treatment, including bispecific antibodies, CAR-Ts, and so on?
No, I think it will die one day. Double transplant is still there because we can't have access to something better unless in 4th relapse, 5th relapse, 3rd relapse, and it's too late. So currently, as I said, we are doing in Bologna double transplant for ultra-high-risk patients. But because after first transplant, I just can give LEN. So I'm not happy to give LEN maintenance, and that's it, you know. And so, okay, let's do a double transplant. The day I will be able to use bispecific or CAR-T, I think the double transplant. I'm not a fond of double transplant because of the complication, because of the patient, because of SPM, because of many. And also, I pass quickly, but in the French study, the increase in the MRD negativity rate between the first and the second transplant is very few, very narrow. So I'm not sure what is really giving, but we have these results also from my center of the EMNO2. So we are still there, but less and less. So we are giving less and less.
Okay, thank you.
Thank you, Elena.
So if there are not any more questions, thank you very much. And now this is my great pleasure to ask Professor Gabor Mikala from Budapest, Hungary, from Southwest Central Hospital, National Institute for hematology and infectious disease to give us the lecture entitled The Importance of Metabolism in Long-Term Myeloma Care.
Thank you very much, and also I would like to thank the organizers and especially Artur for inviting me, and it's also very difficult to talk after so many distinguished speakers, and I recall when Artur invited me, we tried to discuss what would be the area when I can contribute something after these excellent speakers, and he indicated that he will talk about supportive care, and I thought that maybe talking a little bit about something borderline to supportive care is metabolism and nutrition and its importance in the long-term myeloma care, maybe something I can discuss. So let's start that our goal is ultimately to cure multiple myeloma, but unfortunately we have to admit that in most cases we fail in the curative attempt, so we cannot cure myeloma. So what we face is really marathon running where every little thing helps on the way. So maybe, of course, very important what kind of therapies we can add to the patient as targeted therapies for myeloma, but maybe supportive measures are also really contributory. So, of course, as we learned, if our patients have access to new and innovative therapies, then their results will improve. But as a myeloma physician who treats a lot of patients, very frequently I face a situation that I have the patient sitting next to me and they ask, what can they personally as patients do to support the efficacy of myeloma therapy? And it is difficult because patients may do crazy things according to things they learn from the internet, and I try to go over the literature to understand what we as physicians can really suggest for them to do and which are safe things and also things, metabolic changes in the body that can really be helpful for getting the best therapeutic results. And my analogy comes from sports. And we are just after the Olympic Games, and we also think that in the case of getting the best results in sports depends on training and maybe a little bit about nutrition. But we also learned from the British attempt to get better results in bicycle races that little changes which are unrelated to the sports and unrelated to the bicycle may add up to get the best result. So the British started to get better in cycling because they involved a team who could add little changes which seemed to be unimportant at that point, and it really got the result getting first place at the Tour de France and getting many gold medals in cycling at the Olympic Games, which also is presently true. So these are changes that we think it's not so important with respect to the results, but they do add up, like using rubbing alcohol to clean the tires before the race, or banning the bikini waxing for female patients because they get saddle sores and then they will not do so fast in cycling. So this is something we can do in myeloma. We can try to influence the patient's way of life, and the metabolism of the myeloma cells may change, and that may be the better of the patient. So if we understand the metabolism of the myeloma cell, then we may do better. Of course, we learned the metabolism in the beginning of the medical school, and this is something in biochemistry we thought when we pass the exam, we can forget it. And we will never use these results again. So these are the most important nutrients of the cells, like you can see the glucose and glutamine are coming in from the outside and metabolized, and the citric acid cycle is ongoing in the mitochondria. So it's all ongoing. But we also learned that this is in fact the case in the ideal situation. But in the tumor cells, this is something quite different. because even within the same tumor, different areas of the tumor tumor cells in different areas of the tumor may have totally different metabolism depending on the access to the nutrients, depending on the vasculature, and also access to oxygen. Again, access to oxygen is something really important, but not that important that we may think in the outset of the thinking, because of course, eukaryotic multicellular organisms developed in hypoxic conditions, so our cells are doing pretty well in hypoxia. When we do cell culturing, we soak them in carbon dioxide and they do pretty well. But you can see the differences in this simple figure, that in nutrient-replete conditions, the cells are doing a lot of biosynthetic processes, and they use mitochondria especially to provide metabolites for biosynthesis. And in the nutrient-deprived conditions, which is frequently the case in the middle of extramedullary plasmacytomas, which of course, as we learned, have poor prognosis, they have very different access to the nutrients, and they use autophagy and macropinocytosis to get the glutamine they need for metabolism and to provide the necessary nutrients for anabolism and cell division. So when we think about metabolism, we also have to keep this aspect of the tumors in mind. If we skip this basic tumor biology, then we have to think about myeloma. That myeloma cells, for their growth and survival, need two major essential nutrients that they need to uptake from the environment. They need glucose. We use it for everyday diagnostics like PET-CT. We use FDG because myeloma cells love glucose. And we have to know that glutamine is also very, very important for myeloma cell survival. Can we influence these nutrients in the case of the patients? And can we limit somehow myeloma cell access to these nutrients that are really important for their growth and survival? Let's look first about glucose. Of course, as I told that all of you know, myeloma cells really love glucose, but also you have to know that they can survive with low levels. So glucose deprivation, they can survive pretty well if glutamine is present in sufficient amount. But also, we have to admit that hyperglycemia and hyperinsulinemia are supportive for myeloma cell growth, and they are to be avoided. This is important because at least, let's say in Hungary, 30% of the population is overweight. Most of my myeloma patients are overweight, and they have probably insulin resistance. So this is something important to consider. Many patients learn about ketogenic diet, and they learn that in case of certain cancers, it can have a really good effect. And this is especially true about glioblastoma. Of course, in glioblastoma, ketogenic diet can even induce remission. But unfortunately, as far as I check the literature, it has really no effect in the case of multiple myeloma. Intermittent fasting is very popular recently. You know, this is like 16 hours of starving, and the rest of the day you can eat. I checked, and there is an ongoing clinical trial in the United States checking the effect of intermittent fasting, whether it has a beneficial effect on myeloma care. But definitely, what you can tell to your patient is avoiding foods with a high glycemic index is a safe thing. So forget sugar in the coffee and so on and so on. And fruit juices, of course, are also very rich source of fast absorbing glucose. So they may look healthy, but they should be avoided, and so on and so on and so on. Keep the cakes for special days and the like. These are safe advices for your patients. Many of our patients have diabetes. And certain anti-diabetic agents have been shown in retrospective studies to be effective to control multiple myeloma. And the evidence is strongest for metformin and also for SGLT2 inhibitors. First, let's talk a few words about metformin. Is known to decrease the risk of progression of myeloma and may increase the progression-free survival after the stem cell transplantation. So if you have a diabetic patient, it is well done if you tell to the patients not to stop metformin if it is indicated well. And if the patient does not take metformin, consider diabetic patients to be on metformin if it is not contraindicated. But the situation is not that simple. Of course, metformin has a good activity on the pancreatic cells and the liver cells, but for myeloma cells, it needs the organic cation transporter to enter. And not all myeloma cells express this protein, and if this protein is not present in the myeloma cell, metformin will have no activity. So again, this is something possible to test. I checked, and unfortunately, there is no commercial antibody available to this to put it into your flow cytometry to check it whether it's possible, but maybe sooner it will be possible. And metformin activity is through activation of the AMP signaling pathway. So this is kind of the patient will feel that it's starving. SGLT inhibitors are very popular recently in cardiology and nephrology. A lot of patients get that for not just for diabetes, but also to improve kidney and cardiac function. And of course, they also cause metabolic deprivation. They decrease the blood glucose level because much of the glucose is passing through the urine, and the patient is getting also to a catabolic situation, and this is something possibly beneficial also in the case of myeloma. And also there may be some direct effect comparable to metformin on mitochondria as well. GLP agonist, Ozempic, of course, it's something very popular recently, but we also have some results in the case of multiple myeloma that fat myeloma patients with diabetes who received GLP-1 agonist, they had less progression from MGUS to multiple myeloma, and this is maybe something to consider if you have obese diabetic patients with multiple myeloma, that you may have these patients treated with GLP agonists. But on the other hand, GLP agonists have some T-cell regulatory functions which may not be so helpful. So I think this needs a certain level of caution. Let's switch to glutamine. Glutamine is an amino acid with the highest concentration in the bodily fluids and the serum. And of course, as you may remember the mitochondrial picture, glutamine is very important for the mitochondria to maintain the activity of the Krebs cycle, because the Krebs cycle metabolites are used for anabolic processes and exit the mitochondria, and glutamine is used for anaplerosis. Myeloma cells cannot synthesize glutamine, but they have some level of glutaminase, so they really completely rely on external glutamine. Glutamine is present in all kinds of foodstuff. It's a very common amino acid, and its intake cannot be limited because every food contains glutamine. So this is something that only complete starvation can decrease the amount of glutamine intake. But safely, you can say that glutamine, most of the glutamine you uptake from the food is retained in the intestinal mucosa. This we learned that some of the bodybuilders who take glutamine to increase muscle mass fail to do so because the radiolabeled glutamine is retained in the intestinal mucosa. But can we somehow safely and effectively limit myeloma cell access to glutamine? And yes, we can. And this is something which is called physical exercise, because muscle, after recovery from exercise, is uptaking glutamine, and as you can see on that small insert figure, glutamine levels may significantly drop after physical exercise. And some results say that 45 minutes of physical exercise cause about 30 to 40% decrease, but a longer exercise may cause a 6 to 9 hour glutamine decreasing effect. And statisticians say that every 1 hour you exercise increases your expected lifespan by 3 hours. So this is again something you can tell to the patient, that moderate physical exercise is really good, and they should work, and exercise is good not just by general well-being increase and decrease of muscle loss due to steroids, for instance, but also it may have a direct effect on the myeloma. So this is something easy to explain to the patients, and it's good to know to them. And again, this effect is attempted to be targeted by glutamine transport inhibitors by pharmaceutical companies, but these results are not mature yet, so we don't know whether this is going to be a really helpful attempt. And what other things we can tell to the patients, which we have at least some retrospective data? Aspirin use. A lot of patients, especially above the age of 55, by cardiovascular prophylaxis, they use aspirin. And there are some results that regular aspirin use decreases myeloma-specific mortality by the hazardness of 0.61. This would be a respectable result in a clinical trial for a new drug. So this is something, mortality decrease by 37% is something really considerable. So if the patient has no contraindication, then probably the patient is well advised to have aspirin. Statins. I think most patients who visit cardiologists for any kind of cardiology problem, they will get prescribed statins, at least in Hungary. I don't know in your country. So statins are prescribed quite commonly to decrease cardiovascular mortality, but it looks, again, from retrospective populational studies that myeloma-specific mortality is decreased by those who take statins at least for 6 months, but the effect is increasing by longer duration. And a larger dose of statin may be better than a lower dose. With the statins, the problem is that they have very high first-pass effect, and most of the statins are cleared by the liver in the first pass. And maybe there are some results that the anti-tumor effect of statins are not the same, and the rosuvastatin may be a little bit weaker than other statins. Who knows? We will learn it later. But again, if your patient is already taking statins by cardiovascular indication, I think you are advising well the patient to keep statins if possible, because they may be also beneficial for myeloma. And what may be the reason that they are beneficial for myeloma? Like the biosynthesis, the mevalonate pathway is inhibited, and for a long time we thought that this is something related to the RAS farnesylation, but probably this is not something really important. But this may be due to coenzyme Q biosynthesis, and this is one reason to tell your patient not to use coenzyme Q10 as a supplement, because at least in Hungary, a lot of patients are taking that as a supplement. I think that is something not very well advised to do in the case of tumor present in their body. And this is my very last slide. This is about microbiome connection to metabolism and adiposity. And of course, the microbiome and the adipose tissue are somehow in connection to each other. And Of course, there are much better experts in this room about microbiome than myself, but propionate and other short-chain fatty acids are very important to regulate insulin resistance. And of course, the controversy of metformin is also present because it will also change the microbiome. And of course, you can try to change the microbiome by eating healthy. And that's always a good advice to stay healthy and maintain a diet that is considered good for your microbiome and staying healthy. And again, I would like to thank your attention and to show that these two countries and two capitals like Kraków and Budapest share a lot of similarities, not just being major cities of the former Austria-Hungary monarchy, but also friendly capitals or large cities between Hungary and Poland. Thank you very much.
Thank you very much, Professor Mikala, for your very interesting lecture. Professor Jędrzejczyk.
What about metabolic combo? That is aspirin, statin, and metformin. I am taking this already.
Yeah, well, a lot of patients do. I mean, at least in my myeloma patients, most of them have cardiovascular problems because of their age and inactivity and obesity. Yeah, of course.
For other reasons,
yeah,
but
yeah.
I can confess this actually has minimal adverse reactions. So
there are many reports and meta-analysis concerning the role of vitamin D as for the strong association between the level of vitamin D and the incidence of myeloma, multiple myeloma. You said that statins block the HMG enzyme, and the production of vitamin D would be reduced. How it looks like in this meta-analysis where a higher level of vitamin D protects the incidence of many other neoplasm as well, including multiple myeloma.
Yeah, I am aware of that situation that vitamin D, when it is produced in your skin by UV light, that process is inhibited by statins. That is correct. But of course, vitamin D that is uptaken internally, that is not influenced.
Yeah, this is good answer. What about the other lipid-soluble vitamins, including A, E, K2? Do you have some recommendation also in this field?
I am aware of one paper which indicated vitamin K being beneficial for myeloma, but also with respect to vitamin K, it's still controversial because of the different types of the prenyl chain length may matter, and this is not fully known. And of course, vitamin K rather belongs to ARTUR because it has an effect on bone metabolism, which is also influencing...
K1, yes.
Yeah.
K2, mostly immunologic effects. Yes. Are there any questions in the meantime? Yes. Dr. Bata.
Thank you, great speech. I've got a question about the microbiome, because I'm really interested in the microbiome and the connection with the cancer. I've got the results that newly diagnosed multiple myeloma patients before in treatment have significant lower relative abundance in bacteria involved in short-chain fatty acids. And can I ask you, have you ever do microbiome transplant, or have you got any experience in that? And have you got any experience in nutrition treatment?
Yeah, with respect to microbiome, we are collecting the stools of our myeloma patients, but we haven't analyzed them yet. But we did microbiome transfer in the case of steroid refractory graft-versus-host disease, and we did see some good response. So I don't know about myeloma and transplantation and so on, but in the case of steroid-refractory GVHD, enteral microbial transfer, we do see a beneficial effect.
Yes, thank you.
Professor Mikala, I like your lecture very much. Even 2,000 years ago, the father of medicine, Hippocrates, used to say to physicians, you have to take into consideration whatever could help in your treatment of your patient, including diet, including physical exercise. And you are very right that many of our patients ask us what they could do for their disease, not only our treatment, intravenous, transplantation, blah, blah, blah. So generally I say you have to exercise as much as possible your muscles because it keeps your failing bones and so on and so on. You have to drink a lot and fluid, of course. And you mentioned a lot of a problem of the diet, which I think is very important. One of the aspects you said is aspirin, acetylsalicylic acid. I think it could work on two ways. One, that many of our treatment modalities increase coagulation, so probably we could decrease complications, eventual complication of...
And also low-level inflammation, especially
absolutely.
by adipokines, yes.
Yeah. And secondly, as you know, acetylsalicylic acid as inhibitor of cyclooxygenase, decreasing prostaglandins, per se are not only anti-inflammatory drugs, but they are also immunomodulatory, increasing. Aspirin in vitro, both in vitro and in vivo, increase production of interleukin-2, gamma interferon. We have heard a lot about the immune system today. So I think aspirin as an additive element by modulating in positive way immune system could be some explanation of the prolonged survival and less relapse. So congratulations, not easy task, I know, among the molecular biologists to say about diet, but I think that is very important. And if we could help, let's say, in 10–15% of our patients, we have to take into consideration to be optimal physicians and therapeutic people. Thank you very much. Ladies and gentlemen, I have a pleasure to invite spiritus movens of our meeting, my pupil, Professor Artur Jurczyszyzyn, who for many years, I think Artur 25 years, is being involved very deeply in multiple myeloma problems, and the previous lecture to some extent pathway to what you are going to say, that this is supportive care in multiple myeloma patient, and you are one of the not very many hematologists in Poland who not only believe in that, realize in life, but you did organize special system for helping our patient, their self-involvement in the treatment, because we cannot treat the patient only with infusion and drugs without his or her involvement, not only in believing that it's possible to prolong their life, but also to have some influence of the outcomes of our modern therapy. Artur Jurczyszyzyn, stage is yours.
Thank you. Thank you. Thank you for kind words. Professor Skotnicki was my mentor for many years. I am a physician for the last 3 decades almost, and I feel like myeloma doctor, but I'm of course hematologist, and I focus on very narrow of hematology. This is, you heard beautiful speeches, talks by myeloma doctors, and we are doing very similar things in many countries like United States, Spain, Italy, Hungary. We treat many patients in the same way. We can speak the same language. So we are, I think, in 2024, in very beautiful time for patients and very exhausted, we are very happy that we have so many drugs in this disease, but patient can live longer, and during this time, patient could have some support. And we should know that we are getting older, and in 2024-25, we are here, and probably, I don't know if I will be alive in 2050, but if yes, I will be in this percentage of people, more than 30%, 60 years old of age, and all Europe will be very old, and also America and Asia, as you see here. So, myeloma is a disease of old people, and as you see here, now in this country we have about 3,000 myeloma patients every year, and patients with this disease is about 10,000 in Poland. And I'm sure in 2050 will be 3 times more, probably, and I hope we'll live in a world that we can find drugs which will be curable, but it's a problem. You saw this slide by David Wiesel, and I will not tell details about this, but after 2020, we are in the world where immunotherapy is a leader. We are waiting for reimbursement in our country, CAR T cells and teclistamab, elranatamab, and talquetamab, because for high-risk patients like Elena told, there is opportunity for treat these patients. Last 20 years, as I told, I am a physician from 1996 exactly, and during my career and my medical work, I saw nice progress. We start from MP and VAT chemotherapy, and now for last 4 years we have beautiful drugs and very effective drugs. But of course we are hematologists, and we should collaborate to our colleagues who are neurosurgeons, orthopedics, nephrologists, etc. And we are very happy that we moved to a new hospital where in one place, patients with myeloma can find this specialist. Our goal is to control disease. Of course, this is the most important. And the most important is also improved quality of life. And exactly a year ago, it was established a committee of quality of life, and the leader is Surbi Sidana. She is here, and we are focusing on quality of life of our patients because this is very important for us. And everybody knows that deep and durable response is very important, and we should prevent disease-related complications. It's a lot connecting to disease and also connecting to our drugs. Many of these drugs can limit potential toxicities. We should know that patients with myeloma, a lot of patients, like 80%, has skeletal events. Also, we use a drug, for example, thalidomide or bortezomib can cause peripheral neuropathy. And another drugs like pomalidomide or lenalidomide cause thromboembolism. And of course, a lot of new drugs, bites and CARs can use infection and cytopenias. And we should know that about 25–30% of our patients has renal disease on the beginning, and 50% of this patient has this renal disease during the therapy. Of course, some of these patients, some of these drugs can cause heart problems, and this is a big problem for our patients. I mean, fatigue. Sometimes I'm asking patients, what's your main problem? And many patients is answering that big fatigue, it's a big problem. It's connecting, of course, because of anemia. First, maybe we can focus on bone health and bone disease. This is very important for our patients because about 80% of our patients has this on the diagnosis, and this is connecting to osteolytic lesions, sometimes hypercalcemia and fractures. And we can prevent, of course, these complications because we can use bisphosphonates and also denosumab. Our patients can use zoledronic acid or pamidronic acid for a year and later every three months. And this should use and together with anti-myeloma therapy. And then it helps patients for sure. Some of patients don't tolerate these drugs, and we can use denosumab. This is very attractive monoclonal antibody, and for last 2 years, I think in Poland we have programmed to use this drug also. Another problem with this disease is renal problem. It's sometimes very complicated because patients can be in the ward, in the hematology, in the nephrology ward, and in our hospital now, nephrology ward is very close to hematology, so we can collaborate and patient can be dialyzed very shortly. On the beginning, every patient who has initial work, and typical for myeloma is myeloma cast nephropathy. It's very important to collaborate with nephrologists because sometimes patients could have renal kidney biopsy. It's very important when you suspect MGRS. We published 2 years ago a paper. This is still the highest number of patients with MGRS in real-world data. Together with many centers in the world, we collected about 300 MGRS patients, and we have very interesting results after this. After this paper, we know that amyloidosis is the most prevalent type of MGRS. It's about 70% of these cases. Another situation, it could be non-amyloidosis MID. Most patients receive treatment, and a lot of these patients receive transplantation also. So the point is that we should collaborate with nephrologists because we can't diagnose MGRS without kidney biopsy. And this is very important for the diagnosis. As you heard, bortezomib it was a game changer, and in this situation, when you have a patient with MGRS, you can use this drug. And of course, you can use alone, but better to combine with other drugs like IMiDs and others, and you have very good results. And I would like to point you on this slide because this is practical slide. It was a very nice paper published a couple of weeks ago regarding bortezomib dosage. Bortezomib dosage matters. What does it mean? Our patients, I use only 1 time a week bortezomib because, as you see here, this is similar progression-free survival and similar overall survival. It was a paper done in many centers in United States. And bortezomib administration, it's very important because of the safety. As you see here, almost 35% patients has peripheral neuropathy. It's a big issue in these patients. And patient who has a bortezomib 1 time a week, only 18%. I have many times a discussion with doctors because you have programs and you should follow these programs, of course, but you are a doctor and you should think about your patient and you should think about this, that bortezomib twice a week is toxic. And after this paper, you can use only 1 a week, and it works the same like 2 times a week, but a patient will be very happy with no peripheral neuropathy. Another point is it's anti-myeloma therapy treatment for renal insufficiency. You can use this drug like carfilzomib, ixazomib, lenalidomide, and pomalidomide. Regarding lenalidomide, you should remember that it's very important the dosage. Of course, when patients has renal insufficiency, you should avoid 25 milligrams and also 50 milligrams. But for example, pomalidomide, it's no problem. But regarding practical point of view, I use only 2 milligrams, not 4 milligrams. I remember a paper from Mayo Clinic, and 2 milligrams, it works the same like 4 milligrams. So it's very important, and less is more sometimes. In this situation, it's very important for our patients. Another situation, it's very important when you have a patient on the beginning of treatment regarding renal insufficiency. It's very important to give high-dose dexamethasone, but later you can use safely anti-CD30-based triplets, and it works very good. The big issue is infections in our patients. This is very important, and infections, we done a paper, it was analysis of Polish myeloma group regarding mortality, and infections was as a first reason of this mortality until 1 year. But we have vaccination, and this is a recommendation to vaccinate all patients regarding COVID, regarding herpes zoster, meningococci, influenza, pneumococcal Haemophilus influenzae, and also I can add another RSV, respiratory syncytial virus. Sometimes you can ask when you should do it. Of course, it's important to do it during the treatment, but sometimes it's a problem because the patient is on the active treatment. It depends of patient. It's of course personalized situation. Every patient who should has prophylaxis for infection, especially on the beginning when during first 3-6 months it's a problem for our patients because it could be dangerous. Our treatment, especially quadruple daratumumab, bortezomib, lenalidomide, and dexamethasone. It's very active treatment, but prophylaxis for infection is very important. I use also levofloxacin for our patient, aciclovir. Aciclovir also is sometimes Biceptol. And several studies, large studies using combination therapy for myeloma has demonstrated increased risk of serious cardiovascular adverse events. It's an issue, and it was a very nice paper published 2 years ago regarding myeloma drug-related cardiovascular toxicities. You know that carfilzomib is very good drug and very active, but you should remember, of course, that it could be sometimes dangerous for heart. And again, less is more, and I don't use 2 times a week carfilzomib, only 1 time a week, it's enough. Another drugs is like lenalidomide and pomalidomide. It could be problem regarding venous thromboembolism, and all patients should be on prophylaxis. And this is a selected recommendation for baseline risk assessment and monitoring. All patients, the best situation is when you have a cardiologist specialist, and sometimes you can consult patients, but always you should measure blood pressure and you should examine your patients, because a patient is coming every week or sometimes every 2 weeks, and patient is telling you about new symptoms, and these new symptoms it could be connecting to your drugs. Patients with myeloma is treated new drugs, and this is very important regarding quality of life. This is important especially now because we have such new beautiful drugs like talquetamab, and talquetamab is very good, but everybody knows about quality of life after talquetamab. I remember a talk done by Mohamed Mohty, and he told about talquetamab and about dyscrasia, and he told that it's not possible to taste good French wine because patient is losing a taste. He or she is alive, but it's not possible to taste something. It's a problem also with nails, with skin, and I'm very happy that we start to think about quality of life of our patients. Because it was not measured until now, and the reporting was, as you see here, only in half of studies. So this is still gaps in quality of life, and we should think about this in new trials, especially now when we have so many new drugs. So I invite you to to San Diego this year. I will not tell you details about this, about quality of life. This is a beautiful Perseus trial, but believe me that this is the quality of life of our patients after quadruple therapy and transplantation, and later after when patient is on the maintenance daratumumab and lenalidomide, the quality of life is very good. As like somebody told, the progression-free survival in Perseus trial is very long, and this is at the moment standard of care for our patients. We are waiting. I know that FDA approved DARA VRD and transplantation and lenalidomide plus bortezomib as a maintenance, and we are waiting to do it by EMA now. On the end, I would like to share with my PhD student, Dr. Anna Suska. She done a PhD a year ago, and she proved in her work that lifestyle with physical activity seems to play a key role. What does it mean? This study was done regarding impact of quality of life and life environmental exposure to etiology for multiple myeloma. It was a center case control study in 20 hematology centers, mostly Polish hematology clinic, and also 5 outpatient clinics in Poland. It was a very detailed questionnaire about potential risk factors, including social lives, environmental, etc. It was almost 300 myeloma patients, and control groups 208. And regarding lifestyle, sport practice systematically for at least half a year play a protective role in multiple myeloma. Among these factors, harmful exposure, including pesticide, asphalt, coal dust, and chemicals, it was not so important. We are waiting for publication of her work. So lifestyle is very important for our patients, with physical activity seems to play a key role in this situation. And this is a proof published a couple of weeks ago by Jens Hillengas, our colleagues, who proved that T-cell exhaustion markers in multiple myeloma patients is lower after physical activity and intervention. And we organized 4 years ago exactly a Kraków Nordic myeloma group, and we practice every week, 2 times a week now. In the past it was 1 time a week, and I know that T-cell exhaustion marker, it was proof, and we'll do practice still, I hope. And this is my last slide. We are happy that Professor Bob Kyle, who is now 97 years old gentleman, wrote a letter to us and say you greetings from Mayo Clinic. Thank you.
Thank you, Artur, very much. I think quality of life has great impact on our T-cell activity, in general immune reactivity, and quality of life is not only important for our patient, it's also important for all of us. physicians who are taking care about them and getting better, greater satisfaction of effectiveness of treatment, we increase our quality of life. Is anybody from audience suffering of quality of life in Kraków while being in this meeting organized by this young man? No, nobody. Everybody is happy, quality of life is great. Artur, tell me, now will be your lecture or will be movie?
It will be movie because we have director Paweł Wysoczański here. Paweł, come here. And we have special situation because exactly 140 years ago we have anniversary of Ludwig Hirschfeld, and exactly 70 years ago he died. And because of this, Paweł done beautiful film Mensch, and maybe you can tell something.
Good afternoon, ladies and gentlemen. Well, I'm not a good speaker. You're much, much better. My way of saying things is movies, so I want to say I'm proud to be here. Thank you, Artur, for an invitation. The title of the film is Mensch. We shoot this film for many years. The film was shot in the United States, in Switzerland, in Serbia, in Germany, last but not least in Poland. Ludwig Hirschfeld is not a well-known person, but he's absolutely amazing, one and only, one of a kind. And I don't want to speak more. With pleasure, I will discuss with you after the screening, but right now the film Mensch. Thank you.
Just a few words before the film. Good afternoon. My name is Maria Surowska. I've been living with multiple myeloma for almost 8 years. Professor Artur Jurczyszyszyn and the magnificent attendees from all over the world who came to Kraków to take part in the 12th International Conference. On behalf of hematology patients, we would like to thank you for your special interest in new ways of treating multiple myeloma to make our life better and longer. We still believe that our recovery is near. We are very grateful to Professor Jurczyszyszyn for his individual attention to each patient. Thank you, Professor, for your help at any time, for organizing many events and meetings for patients and their families. Thank you so much.